Good morning, ladies and gentlemen. At the outset, I would like to thank the organizers of MEOM and especially Dr. Alamri for having me here. As far as now, our worthy speakers have detailed you about the foreign bodies and the trauma of the interior segment and of the globe, what all images we need. Now, what if there is a foreign body lodged in the orbit and then the patient is reporting to us? The patient may be coming to us primarily or patient may be coming to us after a while. So in this talk, I would detail about what all options do we have and what type of presentations we may have with the patients. The term intraorbital foreign body refers to a foreign body that is within the orbit but outside the globe. It usually occurs after a high velocity injury, accidents, or the gunshot like injuries, or some splinter which is in a very high speed. But a trivial trauma can also cause it. So, a proper history with the duration of the injury and the type of injury is very important because that will give you a guidance, primary guidance of what are you dealing with. The time to presentation is very variable. Sometimes the patient presents to you within hours, but sometimes the patient has multiple trauma and he or she is being treated elsewhere for many days, weeks, or even months together, or the patient forget until unless the foreign body starts having some complications. The patient may present to you after so many years as well. These type of foreign body in our North Indian scenario is generally seen that it's more commoner in males than in females, most likely because of their occupational hazards, their way of traveling, and their way of involving into various conditions where they may inflict trauma and injuries. Whether it is an orbital or whatever injury, but a detailed ophthalmic examination is must in all the cases, especially the documentation of the vision and the type of globe you have, because most of these cases may also have medical legal implications. All these type of patients may have some imaging either done or you may need to do it depending upon the type of foreign body you are suspecting. Could it be a soft like a wooden or a metallic foreign body? My previous speaker has very much detailed about the various type of foreign bodies and the type of images which you may be doing. So ultrasonography, X-ray, CT scan or MRI, these all can be used depending upon the type of foreign body and the location of the foreign body. CT scan generally gives a good idea about the bony landmarks and also about the metallic foreign body, but MRI is better for the wooden type of foreign bodies. So as I said, the type of injury is very important. The motor vehicle type of accidents, the industrial accidents, the violent assaults by various fights or something. The sports injuries are also common. Visual disturbances needs to be noticed whether the patient has a loss of vision or only a decreased vision. Diplopia in case of the foreign body impacting the globe, or even there is muscle trauma. So bleeding from the nose or the loss of consciousness is again taken care of. Modes of injuries, the most common being the road traffic accidents, occupational hazards, gunshots, ear gun pellets, iron splinters, glass pieces, blasts, cracker injuries, vegetative injuries. All these type of injuries can be leading to orbital foreign body. And in these type of cases, you should know what type of injury can cause what type of foreign body. The patient may have various presentations like diminution of vision, pain, bleeding, proptosis, post-traumatic ptosis, or may come up with draining sinus fistulas, purulent fistulas, ocular congestion, discharge, and sinusitis. So there could be either one or multiple presentations with the patient. The management strategies depend upon whether the risk associated with the foreign body retention, whether it's causing an infection or the mass effect, versus risk associated with the surgical exploration, whether it may cause some further damage to the body, to the eye, to the orbital structures. So you should, depending upon whether your patient will be benefited by your surgery or will be hampered more, you finally decide upon whether you're going in for a procedure or not. So the removal of the foreign body is important, but you should also weigh the risks of this surgery with the potential benefit. Management strategy also varies with the type of foreign body which you are having. The metal and the glass foreign body is generally well tolerated, whereas the wooden and vegetable matter are poorly tolerated. So I'll discuss a couple of scenarios. Like this patient came to us with the accident during his occupation. He's a mason and he was working with the grinder, and he had a splinter entering into the eye. The globe was ruptured, and as you see in this, sorry. As you see here in the coronal section, there is a large foreign body which appears to be a metallic foreign body going vertical from the anterior into the posterior orbit, and the extent of the foreign body is seen on this section, that it's large foreign body. An axial section shows you the depth of the foreign body, that it's reaching beyond the mid-orbit, and the globe is totally ruptured. So the patient was explained nil visual prognosis, and the surgery was proceeded. Here we try to first dissociate the foreign body from the surrounding tissues by doing meticulous dissection, and with the blunt forceps or the artery forceps, we pulled the foreign body. You see such a huge splinter was there within the orbit, and it has totally ruptured the eyeball and caused disruption to the orbital structures as well. So you can have these type of foreign bodies, but sometimes you have a very small entry wound or a small sinus which is there, but the underlying trauma could be a large one. So this second case is a similar one. Seeing this gentleman, hardly you feel that there is something, sorry, there on the face, but he had a sinus draining in the superior supromedial part, and he had been earlier operated 5 times, mind me, 5 times in one of the world's renowned hospital for the foreign body removal, but still he had this abscess formation in this coronal section you see, and this down section shows that there is some foreign body still there. This MRI suggests that there was a wooden foreign body, though the person was not very clear about the type of injury because he was drunk when he fell down on the ground, and I suspected that because he fell down on the ground next to his house. Can I have the slide for just a couple of minutes? We are having time because we had speakers not there. Thank you very much. So I suspected a wooden foreign body, and in this case you see when I was removing this pus from this, there was foreign body which I could remove from there. Here is the wooden foreign body which was coming out in piecemeal. One wooden foreign body removed from here, you see. And the problem with the wooden foreign body is not every time you are lucky to have this removal at this one go. Sometimes it comes in a piecemeal. In the second slide you see that another piece is coming up now. So you have to keep on digging, exploring till you are satisfied or you are confident that you would have removed all of the wooden pieces, because even a smaller wooden piece, if left in there, would again lead to the problems. Wood will be a major problem. So there were so many multiple attempts of bringing out so many different pieces out from the orbit, small little bits, and this was around 3-4 years back that he had this trauma, and he had been operated 5 times in a John Hopkins hospital. So initially there was only this pus which came out, but later on you see in the bottle so many foreign bodies, the wooden foreign bodies were removed. So mind me, wooden foreign body is a real nuisance. A few more results, again wooden foreign bodies from the orbit. This is again a big metallic foreign body from the hammer and chisel type of injury, which is again very common. The splinter becomes like a rocket and enters the orbit or the structures around. Gun bullet injuries are again very common in the different scenarios. Radiological features depends and signifies the importance what location of the foreign body is, whether it's in the orbital apex. If it is behind in the very posterior orbital apex and it is not causing any harm, you can decide not to touch the foreign body. Like in this case, it was very close to the orbital apex, and sometimes it is on the optic nerve or just next to the optic nerve. If it is causing injury to the vision, then you should remove it. If it is not, then you should explain the patient that during the surgical procedure he may have some injury. Thank you very much for your attention.